Hello everyone, good evening. Welcome back to another session of Surgical Fix. Today's topic will be on ERCP, and I would like to remind everyone, for those who don't know me, my name is Dr. Ali Khayat, and I'm a resident in Kuwaiti Board of General Surgery, and I'm the Assistant Director of Surgery Kuwait. I will be your host for today, and I would like to introduce our guest speaker for today. He's Dr. Ali Ali, a gastroenterologist, where he graduated from Ireland and followed by his medical school, where he followed his board residency in internal medicine, University of Toronto, and followed by gastroenterology in the same university, where he then completed his fellowship in advanced endoscopy fellowship at McGill University and St. Michael's Hospital, University of Toronto. It's a pleasure to have you with us, Dr. Ali Ali. The floor is yours.
Okay, thanks, Ali. So good evening, everyone, and many thanks for this kind introduction. And first of all, I would like to thank the organizing committee for this kind of invitation. So today I'll talk about ERCP, and my goal is just to give an overview and practical talk about ERCP. So my objective today is to define what do we mean by ERCP, what the procedure entails. In addition, I will talk about specific techniques in ERCP, such as cannulation and sphincterotomy. I will talk about the common indications for ERCP, both the biliary as well as the pancreatic indications. In addition, I'll talk about special considerations in ERCP, such as ERCP in altered anatomy, as well as ERCP in pregnancy. And finally, I'll spend a little bit of time at the end talking about the common complications of ERCP and how to manage them. So ERCP, as the name suggests, it's an endoscopic retrograde cholangiopancreatography, initially introduced in the 1960s. So it's a unique procedure since it combines endoscopy as well as fluoroscopy or X-ray, and it is specialized in dealing with pancreatic biliary diseases. So just to give a little bit of history of ERCP, it was initially described in 1968 by a surgeon actually named Dr. William McCune in the States. But really the use of ERCP was popularized in the 1970s, in the early 1970s, by a gastroenterologist named Peter Cotton, on here, who published a case series of 60 diagnostic ERCPs in 1972. So initially, ERCP was purely diagnostic. We can just go in, do a cholangiogram, confirm there's a pathology, and the patient will need to go for surgery to fix the problem. But over time, and specifically in 1972, a biliary sphincterotomy was described. And this really changed the ERCP from being a diagnostic test to a therapeutic test. Since with the sphincterotomy, and I'll talk about more what do we mean by sphincterotomy, this allowed us to perform more therapeutic interventions. And this became even more in the 1980s with the introduction of more accessories used in ERCP, most importantly, Stent by Sohandra. And again, since the 1980s and the 90s, ERCP slowly replaced surgical bile duct exploration and percutaneous drains as the first-line treatment for pancreatic biliary diseases. As I mentioned, when ERCP was first introduced in the 1960s, it was purely diagnostic test, but slowly it became therapeutic test with the introduction of sphincterotomy and the other accessories. Around the same time, specifically in the 80s and the 90s, there was improvement in the radiological modalities, CT, introduction of MRCP in the EUS in the 80s, which allows safer and less invasive method to diagnose pancreatic biliary diseases. I will discuss it more at the end of this talk, which is the complications of ERCP. Since now we have better tests to diagnose pancreatic biliary diseases, and we know ERCP can cause a number of severe complications, ERCP slowly became purely a therapeutic intervention. And this is one of the most important messages I want to deliver today, which is ERCP should not be purely a diagnostic test, but rather ERCP should only be used once we confirm a pathology that requires intervention by another imaging modality. This is really important to keep in mind. Now, what do we do? What do we need when we perform ERCP? So again, since it's both an endoscopic as well as a radiological test, so we need both modalities. When it comes to the endoscopic part, the scope we use is a special kind of scope known as a duodenoscope, which is a side viewing scope. The one shown here. So the regular gastroscope, which is the one here, is a forward viewing scope, which means the camera is the end here. So this is the typical appearance of the second part of the duodenum. We can see the duodenal folds very well. This is with the forward viewing scope. The problem with the forward viewing scope is we cannot see the major ampulla very well since it's located on the medial wall of the second part of the duodenum. So it's around this area up here. So as you can see, you cannot really see it very well with the gastroscope. So it's not very useful in performing ERCPs. And that's why the side viewing scope was introduced to be used in ERCP, since it provides really good images of the major ampulla so we can see it very well. And from there, we can perform different therapeutic interventions. The other difference with the duodenoscope is it has a very large working channel, 4.2 millimeters, which is much bigger than the regular gastroscope, which allows the introduction of different accessories. In addition, it has an extra wheel, which is the elevator, which allows fine movement of the accessories. The other part of ERCP is the fluoroscopy part. So this is the typical ERCP suite. Typically, you'll find an endoscopy cart as well as the C-arm for fluoroscopy, and the patient usually lying down here. And finally, we use an electrosurgical generator, which is similar to the one used in the OT, and this is to perform sphincterotomy and coagulation. When it comes to accessories used in ERCPs, as you can see, we have a lot of accessories now, and this allows performance of different interventions. The first two, the cannula and the sphincterotomy, probably are the two of the most important accessories we use, especially the sphincterotomy. So you'll hear a lot about the sphincterotomy, sphincterotomy. So this is a special kind of cannula, which is bent a little bit. It allows cannulation of the biliary tree, and again, I'll talk more about cannulation. And furthermore, it has this cutting wire here, which allows to cut the sphincter of Oddi to perform sphincterotomy. So we almost always use these accessories, especially the sphincterotomy. Sometimes we need to use a device or accessory called needle knife. And again, I'll talk about the role of needle knife, and typically it's used to perform precut sphincterotomy. And again, I'll talk about what I mean by precut sphincterotomy. At times, we need to take biopsies from strictures, for example. For these, we usually use cytology brush or biopsy forceps. In addition, we have the injection needle, which is the same as the injection needle you use in any endoscopy. We usually use it if you want to inject epinephrine, for example, in case of bleeding. One of the important accessories we use a lot is the guide wire. So similar to the guide wires used by interventional radiology, and this is a crucial kind of accessory which allows to gain access to the bile duct and more importantly, to keep the access to perform different interventions and to place a stent, for example. So this is one of the most important accessories we use. Depending on the indication for the ERCP, but one of the most common indications, CBD stones. To remove the CBD stones, we have a couple of accessories we use commonly. The most common is probably the extraction balloon, which is the one shown here, as well as the basket. One of the newer accessories introduced is the cholangioscope, and I'll talk about it next. And this really has expanded our indications for ERCP and what we can do during ERCP. And the next slide, I'll talk more about the direct cholangioscopy and what we can do with it. And finally, there are different kind of stents we can use during ERCP. They come in different shapes, different sizes. They can be plastic and metal. And again, I'll talk about when should we use these stents. So just to keep in mind, we have a lot of accessories. There are even more accessories, but these are the most common accessories we use during ERCP. So I mentioned cholangioscopy. So cholangioscopy is essentially introducing the scope or a camera inside the bile duct so we can visualize the bile duct directly. The most commonly used is the spyglass cholangioscopy. So you'll hear us a lot talking about spyglass, and this is just a special kind of cholangioscopy which can be operated by a single operator. In the past, there used to be older versions which requires two endoscopists to perform cholangioscopy, one performing the ERCP, the other one manipulating the scope inside the bile duct. But this spyglass cholangioscopy, the main advantage, it allows a single operator to use it. And typically it's a catheter which has a camera at the end, and it's introduced inside the duodenoscope, so inside the biopsy channel, and it has its own wheel here, which allows fine tuning and fine control of this, of the cholangioscope. This is the typical appearance inside the bile duct. So as you can see, we can get really high quality images inside the biliary tree. And not only we can see, but it can also perform different interventions with this spyglass cholangioscopy, such as lithotripsy or breaking down of larger stones, biopsy, direct biopsy of strictures, as well as using a snare and basket to remove stones and stone fragments. Now, what about patient preparation? So like any other procedures, any other endoscopic procedure, consent is the first step. So we typically describe the procedure, the indication, the contraindications, the alternative to the patient. We'll talk about whether the common complications, the serious complications. So consent is a very important part of the procedure. Typically, the patient needs to be MPO. Typically, 6 hours is sufficient before any endoscopic procedure, including ERCP. Very important to know that ERCP, especially when combined with sphincterotomy, is high-risk procedure for bleeding. So this is very important to keep in mind, and that's why we always emphasize that any coagulopathy needs to be corrected before ERCP, especially if we're planning on doing sphincterotomy. So we need the INR to be less than 1.5. We need the platelet count to be at least 50, and any anticoagulation should be held for a proper amount of time before the procedure. This is very important if we're planning on doing sphincterotomy. At times, the patient already had a sphincterotomy in the past. It may not be as essential. Sometimes if we cannot wait, for example, the patient has severe cholangitis and we cannot wait, and we just want to insert a stent, it's okay. But again, we cannot perform sphincterotomy if the patient has coagulopathy. When it comes to management of anticoagulation before ERCP, I didn't mention the details, but if you want to read the guidelines, this is one of the best guidelines you can read it. It describes what to do with every anticoagulant before ERCP. The most important thing I want to say, aspirin is safe. So you can continue aspirin even during ERCP. We don't really worry about it too much, but every other anticoagulant should be held. The other important step is stable cardiopulmonary status of the patient. So this is even true for patients who may have severe cholangitis, they're severely septic. They still need to be stabilized before we perform ERCP, which means they probably need to go to the ICU, maybe intubated, put them on pressors before we can perform the ERCP. If they are unstable, sometimes ERCP is not possible. They may need to go for percutaneous drain, for example. So this is very important. When it comes to positioning of the patient, so ERCP is unique in the way we place the patient. So we typically place them in the prone position. And the reason why we do this because it allows, especially when we perform cholangiogram and fluoroscopy, it provides better anatomical orientation of the biliary tree. So it's very similar to the MRCP images we see. And that's why we prefer ideally the patient to be in the prone position. This is not always possible. So for example, if the patient is intubated, maybe they're elderly, they cannot lie flat like this. Sometimes we keep them in the supine position, so just lying on their back, which is acceptable. At times we place them in the left lateral position, which is similar to every other endoscopy, but it's less than ideal because the fluoroscopy images become less clear. So we don't prefer the left lateral position. When it comes to sedation, patients for ERCP can be performed under either conscious sedation, so usually midazolam, fentanyl, for example, or ideally, honestly, with deeper sedation. Deeper sedation doesn't always mean general anesthesia and intratracheal intubation, but sometimes just using propofol. Since ERCP can be a prolonged procedure, many times patient may not tolerate it for a very long period of time. So ideally, the patient need deeper sedation. This is not always possible, not in every hospital, honestly, and most of the ERCPs I do are under unconscious sedation, so it's doable, less than ideal, and most guidelines recommend deeper sedation for ERCP. Now, what about antibiotics? So antibiotics or prophylactic antibiotics are not required before most ERCPs, unless the patient obviously have an infection such as cholangitis or cholecystitis. However, there is a role for prophylactic antibiotics. So the common indications for prophylactic antibiotics before ERCP include patients with primary sclerosing cholangitis and patients who are anticipated to have incomplete biliary drainage, for example, Hilar cholangiocarcinoma. And the reason for this is usually the biliary tree is a sterile field, and once we perform ERCP, we are introducing infection into the biliary tree. And normally this is fine because we achieve good biliary drainage, so any source of infection will be drained. However, in cases of PSC where we have multiple strictures, in case of Hilar cholangiocarcinoma where the intrahepatic biliary tree may not drain very well, this will pose a problem since we're introducing an infection, we're not able to drain it very well, and that's why we recommend prophylactic antibiotics before performing ERCP in these patients. In addition, patients who underwent liver transplant, and they require ERCP, whether it's for bile leak or strictures, also need prophylactic antibiotic before ERCP since they're immunocompromised. And finally, whenever we perform cholangioscopy, so the spyglass cholangioscopy, we also recommend prophylactic antibiotics since it's a high-risk procedure for cholangitis. So these are the indications for prophylactic antibiotics. Other patients don't really require antibiotic prophylactically. When it comes to the biliary tree, it's very important to understand the normal anatomy and to understand that there is normal variation in biliary tree. So most of the time, this is the common situation where we encounter where we have the common hepatic duct bifurcating the left main and the right main, and with the right main bifurcating the right anterior segment and the right posterior segment. This is the most common variation in the anatomy we encounter, but just to keep in mind, especially for us who perform ERCP, that sometimes there's variation, especially of the right anterior segment, and it can come off from the hilum, directly from the hilum. It can come from the left side. So just to keep this in mind whenever we perform ERCP. And this is the typical cholangiogram we obtain from ERCP. So this is the duodenoscope, the ERCP scope. And typically we enter the bile duct using a catheter, whether this is a cannula or sphincterotomy or inject contrast, and you can see this is the common bile duct bifurcating into the left main hepatic and the right main hepatic. And this patient specifically underwent cholecystectomy, so you can see the surgical eclipse here. So this is the normal anatomy we typically see during ERCP. The endoscopic appearance of the normal anatomy during endoscopy, this is what we typically see. So typically we're in the second part of the duodenum. So you see the circular folds in the second part of the duodenum, and we can visualize the transverse fold with the major ampulla and the ampulla vata just below it. And again, when we use the duodenoscope, it gives us really good images of the major ampulla. And again, this is the normal anatomy, and this is a normal major ampulla. Now, one of the first steps, and probably the most challenging step, is cannulation. And when we say cannulation, what we mean is introducing a wire, plus or minus the instrument, whether it's a sphincterotomy or cannula, into the desired duct. And as I mentioned, in ERCP, we can perform either pancreatic interventions or biliary interventions. So depending on what's the indication for the ERCP, cannulation means, or biliary cannulation means entering the bile duct, whereas pancreatic cannulation means entering the pancreatic duct. Normally, this is the sphincter of Oddi down here. There's a common channel between the pancreatic duct and the common bile duct, and there's a septum in between the two ducts. So when we're trying to cannulate the bile duct, we usually think of the major ampulla when we look at it here as a clock. So when we're aiming for the bile duct, we usually aim higher up toward the 11 o'clock or 12 o'clock position. So we kind of just adjust the scope position, use the elevator to try to orient the wire and the sphincterotomy in that direction to go up here to the bile duct. But at times we may want to intentionally go to the pancreatic duct. And this is when we aim for the 1 to 4 o'clock position, so in this area here. So again, this technique is important for us who perform ERCP to understand how we can cannulate the bile duct or the pancreatic duct. And as I mentioned, it's the first step in any ERCP, which is cannulation, and it is the most challenging steps. And we cannot perform anything, any intervention, whether it's sphincterotomy, whether it's stent insertion, if we cannot achieve cannulation. So how do we perform cannulation? So this is the major ampulla, and this is a sphincterotome with a guide wire inside. So again, here we're trying to cannulate the bile duct. So we're aiming up toward the 11 o'clock, 12 o'clock position and a little bit of maneuvering. And typically we're able to achieve biliary cannulation. Here we're just at the sphincter, and usually we kind of see a jump once you're past the sphincter. Once we're there, we pass a guide wire, which you can see here, up the bile duct, and inject a contrast to achieve a cholangiogram. In this patient specifically, we can see the bile duct is dilated. And how can we gauge whether it's dilated or not? Typically, we compare it with the scope, the duodenoscope. So the duodenoscope has a diameter of 12 millimeters, so 1.2 centimeter. So we compare it with the bile duct here. And as you can see, the bile duct here probably is about 1.5 bigger than the CBD. So we kind of estimate it. This is probably dilated at 1.7 centimeters, and you can see multiple filling defects here. So these things here, these are CBD stones. So this is a typical cholangiogram we obtain once we achieve cannulation. And again, cannulation is the first step, but after that, we typically follow it by sphincterotomy. And sphincterotomy means just cutting the sphincter of Oddi muscle. So this is how we perform sphincterotomy. So again, we use a sphincterotome, which has a cutting wire on the top here. And again, we're just cutting up toward the 11 o'clock, 12 o'clock position, slowly just cutting up. And we're limited by the duodenal fold. So up here, this is the limit of how much we can go. If we cut even more, we will cause perforation essentially. So we'll go to the retroperitoneum. And again, this is why sphincterotomy is one of the higher risk procedures, because not only we can cause bleeding, but also can cause perforation. And we'll talk about the different kind of perforation as well. So this is sphincterotomy. And again, it's one of the essential steps we perform in ERCP. One of the also essential steps or interventions we can perform in ERCP is stent placement. And I'll talk about different indications for stent placement. Stents can come in different forms. They can be plastic, as can be seen here. They can be metal stent, and even metal stent can be fully covered, uncovered, and I'll talk about the differences between the two. And typically we insert stents whenever we want to achieve biliary drainage for different reasons. Now, as I mentioned, we have different kind of stents. We have plastic stents, we have metal stents. And even the metal stents, they come in different types. They can be uncovered and fully covered. Plastic stents are probably the most commonly used. They come in different shapes. They can be straight. They can be double pigtail. In general, plastic stents are smaller. So they come in different sizes, varying between 7 and 10 French, which is around 3 millimeters. And because of the smaller diameter, their patency is only 2 to 3 months, because they tend to get blocked after that from all the debris in the bile duct. The main advantage of the plastic stents, they're easy to insert, they're inexpensive, and more importantly, they're easily removable, and therefore they're suited for both benign and malignant indications. But there's always a risk with migration with these stents, even though the risk is not very high, but it's something to consider. So plastic stents are very effective, but they're not durable. On the other hand, the metal stents, they have much bigger diameter. So the typical metal stent will have a diameter of 10 millimeters, which is the equivalent of 10 French plastic stents. So they're much bigger than the plastic stents. And because of the bigger diameter, they remain patent for much longer. We say on average 6 months, but sometimes most of the time actually, they remain patent even longer. Now, the difference between the uncovered metal stent and the fully covered stent, with the fully covered stent, there is an outer covering which prevents tissue ingrowth. So with the uncovered stent, since there's nothing covering the metal part, over time, tissue, whether it's benign or malignant, will grow inside the mesh. And therefore, it will become almost impossible to remove uncovered metal stents once they're inserted because of the tissue ingrowth. For the uncovered metal stent, they're best suited for malignant indications because once you put them, you don't need to remove them, and they're very low risk of migration. That's why they're preferred for malignant indication, but they should not be used in benign indications. On the other hand, the fully covered metal stent, they also offer the advantage of the bigger diameter, the longer patency, but also since they're fully covered, they can be removed, like the plastic stents, and therefore they can be used in both benign and malignant indication. And you might wonder, why don't we just use it all the time, since it has the advantage of the plastic stent of removability, yet it's still open, opaque, and longer. Now, because of this outer layer, which prevents the tissue ingrowth, the problem with the fully covered stents is that very high risk of migration. So about 20 to 30% of the time, at least, they will migrate, and which can be a problem, since if you have a migration of the stent, a lot of patients will develop cholangitis. So that's why we don't use them as frequently as you might think, but it's something to consider. So most of the time, achieving biliary cannulation is straightforward. However, there are certain situations where it can be difficult. And this is what we sometimes hear talking about difficult cannulation. This scenario can happen if the major ampulla is located in a difficult location, typically if the patient has a periampullary diverticulum, as in this case here. So you can see the major ampulla on the side here. So it's very difficult to enter. It's not impossible, it can be difficult. And at times, the patient may have these redundant folds, the duodenal fold, which makes the CVD or the bile duct tract tortuous. So these are difficult cannulation or potentially difficult cannulation patients. And there's a certain definition, if you want to read it, for difficult cannulation. Now, even if we encounter a patient with difficult cannulation, there are a few options, or a number of options we can do during ERCP. One of them is to continue trying to cannulate using the standard technique, whether it's with a sphincterotomy or a cannula. So instead of giving up after 5 minutes or 10 minutes, maybe persistent for longer, it may work, but I can tell you, if it doesn't work initially, there's a good chance it will not work. But luckily, we have other techniques. One of the commonly used is the double guide wire technique. And you see us talking about this technique quite a bit, and I'll talk about it in the next slide. And it works really well. Sometimes we perform Precut sphincterotomy, and again, I'll talk about this technique next. But also just to keep in mind that many times just stopping the ERCP and repeating the ERCP after 48 hours is a very valid option, because the longer we try to manipulate the bile duct, the more edema we will have, the more difficult it gets. So the longer you spend trying to achieve biliary cannulation, the more edema, the more difficult. And sometimes it's just better just to stop on that day, come back after 2 days, and it works most of the time if you perform this. And this is maybe an option if the patient is stable, they can wait, but sometimes they have cholangitis, they're sick, this may not be an option. And again, it's very important. Sometimes it's best to if you fail the first time, to ask another endoscopist, more experienced endoscopist, to perform the next ERCP or even during the same procedure to help. So again, this is very important for us as endoscopists to ask for help when it's needed. So I did mention this technique of double guide wire technique. So what do we mean by this? So just because of the orientation of the pancreatic duct, it's more vertical, more straight compared to the bile duct. So sometimes inadvertently the guide wire will go preferentially to the pancreatic duct. So despite the fact we're trying to cannulate the bile duct, it's just because of the orientation of the bile duct or the pancreatic duct. Sometimes the wire prefers to go to the pancreatic duct, and sometimes we can use this to help us to cannulate the bile duct. So what we do with the double guide wire technique, if we enter the bile duct or the pancreatic duct by mistake, so you can see the wire here, this over the spine, this is the pancreatic duct wire. We leave it and we use a second wire to try to cannulate the bile duct. And this works almost always because once you leave a wire in the pancreatic duct, it will straighten the channel between the CBD and the pancreatic duct, and also will block the pancreatic duct. So the second wire will preferentially go to the bile duct. But if we perform this technique, and in fact, any technique which involves manipulation of the pancreatic duct will increase the risk of post-ERCP pancreatitis. So whenever we perform this technique, we prefer to place a pancreatic stent. I will talk about the role of pancreatic stent in prevention of post-ERCP pancreatitis. The second technique we can perform in difficult cannulation is Precut. So Precut sphincterotomy, we use the needle knife, which is this device here. And this patient has a pancreatic stent already. So what we do is, using this needle knife, we cut in the orientation of the bile duct. So we know the bile duct runs in the 11 to 12 o'clock position. So we kind of just cut the duodenal fold on top in that direction. And then just with gentle manipulation, sometimes we can enter the bile duct there. So in this example, it may look simple, may look clean and easy, but I can tell you it's not always this clean and easy. It requires a lot of skills to perform this, the Precut. It is associated with a lot of complications, including bleeding and, more importantly, perforation, and that's why it should only be done by experienced ERCP expert. And many of the complications happen after ERCP is after Precut sphincterotomy. But again, it's a valid option in patients with difficult cannulation. So despite our best effort, even in the best endoscopists, with the most experienced endoscopists, we will fail some of the ERCPs. So inexpert had about 10 to 15% of the time we will fail to achieve cannulation. And if this happens, again, it's not at the end. There are several options. As I mentioned, one of the options is just to repeat the ERCP after 48 hours, just to allow the edema to settle down, and usually becomes easier to cannulate the next time. And this is an option if the patient is not sick. They can wait for another 2 days. But at times, especially if the patient is septic, they're sick, they cannot wait these 48 hours, interventional radiology usually can help. One of the ways is IR-guided percutaneous drain, where they insert a drain into the bile duct to achieve biliary decompression. And another option is IR-guided rendezvous procedure. So the same technique where the interventional radiologist will leave a drain inside the bile duct. They will pass a wire from the percutaneous drain into the duodenum, so across the major ampulla, and from there we can perform ERCP using the interventional radiology wire, and this is called a rendezvous procedure. But now with the introduction of therapeutic endoscopic ultrasound, or EUS, we have a lot of newer options, and I think that you'll hear more and more about EUS-guided rendezvous procedures, as well as EUS-guided biliary drainage in the future. So just keep this in mind. I don't want to go into details about the role of therapeutic EUS, but I think in the future, EUS will replace most of the percutaneous interventions, including rendezvous and drains. So just keep this in mind. Now let's talk about the common indications for ERCP. So ERCP, we have both biliary as well as pancreatic indications. Biliary indications are probably by far the most common. So about 90 to 95% of all ERCPs we perform are for biliary indication. Most commonly CBD stone, but can be Mirizzi syndrome, benign strictures from, for example, chronic pancreatitis, post-liver transplant, malignancy for different reasons, or CBD injury or leaks, whether this is iatrogenic or post-trauma. And there are a number of interventions we can do, including stone removal, stent placement, tissue acquisition, stricture dilatation, among other interventions. Pancreatic interventions not as common, about 5 to 10% of the time probably, and most commonly due to symptomatic chronic pancreatitis, typically for stone removal or stricture dilatation. But there are certain patients with pancreas divisum where we can perform minor ampulla sphincterotomy, as well as in certain patients with pancreatic leak. I will focus today on the biliary indications. I will not talk about the pancreatic indications since they're not very common, but just to keep in mind that there are certain patients with pancreatic pathology that do benefit from ERCP. So by far the most common benign indication is CBD stones. So this is by far the most common for ERCP, especially here in Kuwait. Most of the patients who have CBD stone will have symptoms, whether this is abdominal pain, whether this is obstructive jaundice, cholangitis, or pancreatitis. However, keep in mind that some patients may not have symptoms and they may found to have CBD stone incidentally by imaging done for another reason. And these patients, so any patient with CBD stone, even if they don't have any symptoms, regardless whether it's a small stone, big stone, these patients should undergo ERCP for stone removal. And the reason for this is there have been a number of studies which followed patients who had incidental finding of CBD stone, so completely asymptomatic CBD stone. And if you follow these patients long enough, most of them will develop complications, whether this is cholangitis or this is pancreatitis. And that's why the current guidelines recommend that all patients with CBD stones, regardless of symptoms or stone size, then undergo ERCP or sphincterotomy and stone removal. As I mentioned before, routine prophylactic antibiotics are not required before ERCP in the setting of CBD stone. Obviously, if the patient has cholangitis or cholecystitis, they do require antibiotic for treatment for that indication. And performance of sphincterotomy and stone extraction is successful in more than 80 to 90% of the cases. So we're able to remove the stone after a single ERCP. However, it's some cases we may not be able to remove all the stones, especially if the patient had multiple stones or they had multiple stone fragments. And in that case, we usually place a temporary stent, usually a plastic stent, and come back after 2 to 3 months to remove the stent and complete the job. So most of the time, most of the CBD stones are quite simple. We can manage them at the same session. And this is a typical a case with a CBD stone. So the patient come in with obstructive jaundice. We perform ERCP. We find this filling defect in the distal CBD, and this is how usually CBD stones are seen in ERCP. And what we do typically, again, we try to cannulate the bile duct. So we pass a wire up to the bile duct, and this is the CBD stone, and then we introduce the extraction balloon. And once we introduce the extraction balloon, we just inflate it and just kind of pull back to remove the stone, as you can see here from the major ampulla. So again, most of the time, most of the stones are quite simple. We can remove them easily like this. And again, about 80 to 90% of the time, we're successful. However, not all stones are easy. So there are some stones that are difficult, where clearance may not be possible with a single ERCP or using standard techniques. So there are certain factors that are associated with difficult stones. So there are stones-related factors and there are certain anatomical factors. So the stones-related factors include larger stones. So in general, a stone that is bigger than 15 millimeters is considered a difficult stone. So in this example, for example, you can see this huge filling defect. So this is probably at least 3 centimeter stone in the bile. So we know this is not going to be easy to remove this whole thing across this major and pull it down here. So this probably requires special techniques, which I'll discuss next, to remove it. Sometimes unusual stones with unusual shapes. So like this example here, you can see this stone here, which has this rhomboid shape. So again, this is very difficult to remove without using standard techniques, because you can imagine trying to remove this stone, which has this shape across the major ampulla, which is quite impossible, physically impossible. And also in patients who have multiple CBD stones, like this example, we may not be able to remove all the stones in the same sessions. It might be difficult. But not only stones-related factors are important, but also anatomical factors are important. So the location of the stone is very important. So if the stone is in the cystic duct, these are very difficult, if not even impossible, to remove by standard techniques during ERCP. And sometimes stones in the intrahepatic biliary tree are also very difficult to remove. Not impossible, it might be very difficult to remove using ERCP, especially with the standard techniques. There are certain things we can do, however. If we have a distal CBD narrowing, this will also make removal of the stone very difficult. So even if you have a 5 or 6 millimeter stone, which is typically easy to remove, but if you can imagine, if below it you have a stricture 1 or 2 millimeters, where the diameter of the CBD is about 1 or 2 millimeters, physically it will be impossible to remove these stones using the standard techniques. Now, what are the options in cases of difficult stones? So we can perform mechanical lithotripsy, whereby we crush the stone to make it into smaller fragments that are easier to remove. Sometimes we can perform something called large balloon sphincteroplasty. So essentially, we insert a dilating balloon across the major ampulla and just dilate this balloon into a larger size to make the opening much bigger. So this obviously has limitation because we cannot dilate bigger than the bile duct, otherwise it will cause perforation. So it works very well, but we need a dilated biliary tree to do this. As I mentioned, spyglass cholangioscopy has an important role, which I'll discuss. And finally, just keep in mind, surgery is always an option for patients with difficult stones. So even though ERCP has replaced most of the indications for surgery, especially open bile duct exploration, but there's always a role for surgery in certain patients, and that's why it's very important to have a multidisciplinary meeting when it involves patients with difficult stones. So what about mechanical lithotripsy? So mechanical lithotripsy is done using a special kind of basket. So this is the basket which has a metal sheath. So this is a big stone, as you can see on the cholangiogram. We just grasp it using this special basket, and then using this metal sheath, we slowly just compress on this stone until it breaks down, as you'll see in a second now. So you can see here, it just breaks. So we're just kind of compressing this stone using this metal sheath, and it breaks into smaller fragments that are much easier to remove. So once we break it down, as you can see here, using a basket, we can just remove these fragments. So this is called mechanical lithotripsy, which has an efficacy in stone clearance of about 80 to 90% of the time. However, the bigger the stone, the more difficult or the less efficacious this technique becomes. And just to keep in mind, many of these patients will require multiple ERCP sessions to achieve complete biliary clearance. Another important indication for ERCP is biliary pancreatitis. So as you're all aware, biliary pancreatitis is probably the most common cause of pancreatitis, and it's typically caused by all these tiny, tiny stones in the gallbladder that fall, get impacted at the major ampulla, causing transient elevation in the pressure inside the pancreatic duct, provoking acute pancreatitis. And because of their smaller size, most of these stones will pass spontaneously across the major ampulla after they cause pancreatitis. So this is very important to keep in mind. Even though these stones do cause pancreatitis, but most of them will pass spontaneously. In the past, so if you read the older literature, there was some suggestion that ERCP and sphincterotomy is beneficial in patients with acute severe pancreatitis, regardless whether they have a CBD stone, regardless whether they had cholangitis. However, more recent data suggests that in these patients, so patients with acute severe pancreatitis or predicted severe pancreatitis, do not benefit from ERCP and sphincterotomy, since it has no impact on mortality, organ failure, or infected necrosis. So just keep this in mind. However, there are certain patients with biliary pancreatitis that do require ERCP and sphincterotomy. So what are the indications for this? These are the indications for ERCP and acute pancreatitis. And it's typically for patients with suspected CBD stones. So if you have a patient who presents with cholangitis, so they present clinically with fever, jaundice, and they fit the clinical picture of ascending cholangitis, these patients do benefit from urgent ERCP within 48 hours with sphincterotomy. If the patient is documented to have a CBD stone, whether this is on ultrasound, MRCP, for example, again, these patients do benefit from early ERCP within 72 hours. And if you have a patient with biliary obstruction, their jaundice, and the cutoff we use is, or the guidelines use is 68, plus they have dilated biliary tree on imaging. So, for example, in a CBD of 7 or 8 millimeter on ultrasound. So if you have a patient with fulfills both criteria, so they're jaundice and they have biliary dilatation, regardless if you see a CBD stone or not on the ultrasound, these patients have a high pretest probability of having a CBD stone and should undergo early ERCP within 72 hours. However, all other patients that do not fulfill one of the 3 criteria should not go ERCP directly. So many times we have patients with biliary pancreatitis who might be slightly jaundiced and maybe bilirubin of 30, but normal ultrasound. Or for example, they have slightly dilated CBD 7 or 8 millimeters, but they're not jaundiced. These patients should not undergo ERCP as the first step, but rather should undergo either MRCP or EUS beforehand. And the reason why we do MRCP or EUS, we want to see the biliary tree. If we do document the presence of CBD stone, the patient should undergo ERCP. If there's no evidence of CBD stone on these imaging modalities, these patients should not undergo ERCP. So these are the common indications for ERCP in patients with pancreatitis. Another important indication is Mirizzi syndrome, which is the extrinsic compression of the common hepatic duct by a stone in the cystic duct or infundibulum of the gallbladder. So there's this classification system, I guess you use quite a bit to decide on the surgical management of patients with Mirizzi syndrome. So Mirizzi syndrome is not common, but we do encounter it from time to time in patients with gallbladder stones. And ERCP has an important role in patients with Mirizzi syndrome. Classically, the role of ERCP is to insert a stent, a temporary plastic stent, until the patient can go for surgery, remove the gallbladder and the cystic duct stone, and then after the surgery, we remove the stent. Typically, as I mentioned before, it's very difficult to remove cystic duct stones using ERCP, and that's why traditional standard techniques are usually unsuccessful in cystic duct stones, and that's why classically Mirizzi syndrome is a surgical indication rather than ERCP. However, with the introduction of spyglass, there are some promising data for patients with cystic duct stones causing Mirizzi syndrome that are managed endoscopically, and I'll show you a video now. And this is becoming, I guess, I don't want to say a first line yet, but a valid option in patients who underwent cholecystectomy and now presenting with a cystic duct stone causing Mirizzi syndrome, where really you don't want to take them back to the OR because it might be quite complicated surgery, and really spyglass have changed the practice. So this is an example of a patient who had a cholecystectomy in the past, comes in with obstructive jaundice, and you can see on the MRCP this big filling defect in the cystic duct remnant. And this is the typical appearance of spyglass cholangioscopy. So as you can see, we are able to visualize the bile duct directly. We can see this large stone in the cystic duct, which normally we cannot remove using the standard ERCP technique. But this is EHL probe, which is lithotripsy, which helps to break down stone. And as you can see, it's very efficient at breaking down larger stones, and we can apply the same thing even in larger CBD stones. So using this technique, the spyglass with EHL or laser lithotripsy, it helps break down these larger stones into much smaller fragments that can be removed during ERCP. So just keep this in mind, spyglass cholangioscopy can be useful in certain patients with Mirizzi syndrome. Bile leak is another important indication for ERCP. So bile leak can happen after trauma, after surgery, such as lap chole, liver transplant. And endoscopic therapy is very effective. And typically we perform sphincterotomy with plastic stent placement. There are some data that suggest in patients with bile leak, performance of sphincterotomy alone is probably inferior to the placement of plastic stent. That's why we almost always combine sphincterotomy with plastic stent in patients with bile leak, since this is more effective. In patients with refractory leak, sometimes we place a fully covered metal stent. And most of the time, I want to say more than 90% of the time, this technique will work. But you have to choose your patient carefully. So this is the Strasbourg classification bile duct injury, and this is very helpful in practice to decide which patient should undergo endoscopic therapy as opposed to surgical therapy. And in general, patient with Strasbourg type C, which is this example here, where you have the apparent right hepatic duct leak, they do not benefit from ERCP since this segment is disconnected from the rest of the biliary tree, so placement of a stent or performance in sphincterotomy will not help. In addition, patients with complete CBD transection, they do not benefit from ERCP, and these patients are best served by surgery. So why does plastic stent or sphincterotomy work. So this is an example of patient underwent cholecystectomy. As you can see, this is the cystic duct here or cystic duct stump, and you can see contrast leakage confirming bile leak. The reason why it works because typically the bile flow want to go to the area of least resistance. So if you have a leak in the cystic duct, the bile will preferentially go to this area since it has the lowest pressure. So performing of sphincterotomy or inserting a stent in this area, even if we don't cover the cystic duct, so even if you just perform sphincterotomy, if you place a short stent, this will decrease the pressure in the biliary tree, and therefore the bile now will flow to the area of least resistance, which is across the ampulla, and hence there will be no more bile flow in the cystic duct stump, allowing healing of the fistula. And this works really well. So typically we place a plastic stent, leave it for 6 weeks, come back after 6 weeks, remove the stent, and almost always it will work. As I mentioned, if it doesn't work, sometimes we place a fully covered metal stent, and it almost always works if the plastic didn't work the first time. The last indication I want to talk about, or the benign indication, is ampullectomy. So this is a patient with benign ampullary adenoma. So ampullectomy, which is the removal of the major ampulla endoscopically, it's reserved for a patient with benign ampullary lesion, most commonly adenoma neuroendocrine tumors. So in this patient has an ampullary adenoma. We just place a snare and we can resect it. This is a high-risk procedure that should only be done by experienced ERCP expert. It is a procedure, even though it looks simple here, but I can tell you it is associated with very high risk of complications, most commonly bleeding, pancreatitis, or even perforation. But yet its adverse events is lower compared to major surgery. So some of these patients may require Whipple or even transduodenal resection. It's still associated with lower adverse events. So this is just another important indication for ERCP, even though it's not very common. So moving on to the malignant indications, which are quite common. So ERCP has a very important role in the diagnosis and relief of obstruction in patients with malignant obstruction, whether this is pancreatic cancer, ampullary cancer, cholangiocarcinoma, or even metastatic disease. And the role of ERCP in both tissue acquisition through breast cytology or biopsy forceps, but also has a very important role in stenting and relief of biliary obstruction. So this is a classic example where we have a patient who comes in with painless jaundice and they go CT scan confirming head of pancreas lesion. And here we're performing ERCP. You can see this tight stricture in the distal CBD with dilatation of the intrahepatic or the more proximal biliary tree. So what we typically do during ERCP, we can obtain tissue using this breast cytology. As you can see here, we're just scraping some of the cells. And then we can place a metal stent. So in this example, we're using a fully or uncovered metal stent. So most of the time, especially in pancreatic cancer, this is straightforward, and we can achieve excellent biliary drainage using this intervention. And the same scenario with ampullary cancer. The more complicated situation is patient with cholangiocarcinoma. The reason for this, cholangiocarcinoma is more of a heterogeneous disease because it can be in the intrahepatic cholangiocarcinoma, about 10 to 20% of the patient. It can be Hilar, otherwise known as Klatskin tumor, about 50 to 60% of the time. And it can be distal, so about 20 to 30% of the time. So distal cholangiocarcinoma is straightforward because their approach is the same as patients with ampullary cancer or pancreatic cancer. Whereas patients with intrahepatic, they usually do not benefit from ERCP since the site of the obstruction is very high up in the biliary tree. And so if they do require biliary drainage, usually PTC is the way to go. However, the scenario I want to talk about is the Hilar cholangiocarcinoma. So these are more complicated because not all Hilar cholangiocarcinomas are the same. So the classification system we use is the Bismuth classification for Klatskin tumor. So in patients with type 1 or type 2 Hilar cholangiocarcinoma, these patients probably are best served with ERCP since we're able to insert a stent proximal to the site of the obstruction. Ideally, we insert 2 stents to drain both liver segments, but it's not always required. So type 1 and type 2 are best served with ERCP. However, whenever the obstruction goes higher up in the biliary tree, it becomes more complicated for ERCP, and probably ERCP becomes less efficient in these patients, and probably these patients, so type 3, type 4, are best served with PTC plus or minus ERCP. But again, it's very important, these patients, the Hilar cholangiocarcinoma, they really need to be discussed in a multidisciplinary meeting involving the surgeon, the gastroenterologist, and the radiologist to decide what's the best way to drain. Now, one of the important messages I want to deliver today: not all patients with malignant obstruction will require a routine pre-op drainage. So if the patient is operable, you don't always need to drain them. I'll talk about what are the indications, but just to keep this in mind. And this is especially true for patients with Hilar cholangiocarcinoma, because we can cause a lot of problems and we can make the patient sick by performing ERCP, especially if we're not able to achieve adequate biliary drainage. And that's just emphasizes the importance of prophylactic antibiotic in these patients. And that's why any patient with suspected Hilar cholangiocarcinoma, you really need to get really high quality images before the ERCP, typically with an MRCP. And the reason for this, we want to map the area of the blockage or the obstruction, since if we perform ERCP and we inject contrast on both sides, like in this example, the right and the left, and we only drain the right side, for example, so we place a stent only draining the right side, the patient will develop cholangitis because we're not draining the left side. So that's why it's very important to get an idea before we do the ERCP, so we can plan that we're only going to drain the right side, so we only inject contrast on the right side before the ERCP. The other important reason why we prefer to get either a CT or MR before performing ERCP in these patients is we want to see whether they have atrophic segment of the liver. So there's no point in trying to drain an atrophic segment. So for example, the patient has the left biliary tree or the left liver lobe atrophic. There's no point in placing a stent there to drain it, since it's already atrophic, and probably should be focused on the right side. And our goal is to drain at least 50% of the viable liver volume, which we can only estimate using CT or MR. So again, it's very important to get pre-ERCP high quality images. In general, when it comes to the choice of the stent, we prefer to use plastic stents in patients who are potentially resectable, since again, they can be easily removed. But if the patient is clearly palliative, they will not undergo any surgery, we prefer to use metal stent, usually uncovered metal stent, to achieve biliary drainage. To achieve diagnosis in malignant strictures, as I mentioned, ERCP has an important role. Classically, we use the brush cytology, which is the one here. The problem with brush cytology has low sensitivity of around 40%. So if you get a negative result, it does not really exclude the diagnosis. The same thing applies to biopsy. So again, the sensitivity around 50%. So that's not great with patients with malignant strictures. And again, that's why cholangioscopy with spyglass cholangioscopy is having more of an important role in patients with indeterminate biliary strictures. So patient underwent ERCP or even US and had biopsies that are still not diagnostic, sometimes performing spyglass cholangioscopy with target biopsies. So this is an example here of the patient with a stricture. So we can see the stricture very well, and not only we can see it, but we also can target our biopsy, so we can be very precise. And this has increased the sensitivity of diagnosis to 76%, and there are even newer reports suggesting the sensitivity is increased to 90%. One of the important questions is, when should we perform pre-op biliary drainage in patients with malignant obstruction? So this is very important. As I mentioned before, routine pre-op biliary drainage is not always required in patients who are jaundiced and have malignant obstruction and who are potentially resectable. The reason for this, there are a number of studies which show that routine pre-op drainage may increase the post-operative morbidity, especially infection, may delay surgery. So it's not always recommended, and therefore we always discuss it in a multidisciplinary meeting. However, what are the established indications? So in a patient who you think is operable, and they have malignant obstruction, the clear indications for ERCP before the surgery is cholangitis. So always the patient comes in with cholangitis, they need to be drained. But I have to tell you, it's very uncommon for a patient with malignant obstruction to present with cholangitis without any prior manipulation. Maybe the only exception is ampullary cancer. For some reason, they might get cholangitis even without any manipulation. But for pancreatic cancer or hilar cholangiocarcinoma, it's very uncommon for a patient to present with cholangitis if they never had any prior manipulation. Severe symptoms, especially severe pruritus, is an indication for biliary drainage. If you think there will be delay in the surgery, more than 3 to 4 weeks, and the patient is jaundiced, there's some recommendation probably these patients should undergo ERCP with biliary drainage. And obviously, if they think the patient has a borderline resectable tumor, they will undergo neoadjuvant chemotherapy first, and they're jaundiced. They will require ERCP with stent placement, since many of the chemotherapeutic agents are used, are metabolized and excreted by the liver. The last indication is the more controversial indication. So if you have a patient who's got malignant obstruction and they're operable, but they come into severe jaundice. So by severe jaundice, we need bilirubin of more than 250 and 300, yet they don't have any symptoms. So there are some data suggest that if you operate on these patients and they're quite severely jaundiced, this may increase the post-operative complications, including infection, but this is very controversial. So some experts recommend that these patients should undergo ERCP and stenting regardless of the symptom. Others don't. So again, just re-emphasizing the importance of discussing these patients before performing ERCP. Now, when it comes to stenting, as I mentioned, we have several options. In the case of malignant stricture, the use of plastic stent is a valid option. Typically, it can be used for any obstructive lesion, whether it's distal, whether it's proximal. Really, there are no absolute contraindication for the use of plastic stent. But as I mentioned, the problem with the plastic stent, especially malignancy, they will get obstructed within 2 to 3 months' time. So if you think the patient is palliative, they're not going to go for surgery, probably it's best to avoid the plastic stent and just insert a metal stents, which have higher patency. Uncovered metal stent, they're the preferred stent to use in cases of palliative unresectable tumors. However, they should not be used if the diagnosis is unclear. So if you have a patient with a biliary stricture and you're still not sure whether this is benign or malignant, you should not insert an uncovered metal stent, since once we insert it, it's very difficult to remove it. And that's why until we establish a diagnosis, we prefer not to use an uncovered metal stent. And certainly you should not be placing an uncovered metal stent at the hilum if the patient has a resectable or potentially resectable hilar lesion, since it will interfere with the site of the resection. Just the last comment I have it here is many times patients who have distal tumors, they still can, even if they're potentially resectable, we still can use these metal stents since they're away from the resection margin. The fully covered metal stent, they can be used with any obstructive distal lesion. They should not be used in the hilum, since they can cause blockage of the other side. As I mentioned, the main risk is migration. Now, just special considerations. So I'll talk about patients with altered anatomy, prophylactic sphincterotomy, and pregnancy. So some patients will have altered upper GI anatomy, and this will make ERCP very difficult, if not even impossible. One of the common, or becoming less common now, anatomy is Biliary gastrectomy. In these patients, it is possible to perform ERCP using either a duodenoscope or even a gastroscope. It's quite challenging to try to get to the afferent limb, but it is possible, and typically we can perform ERCP. The same thing applies to patients with Whipple's procedures. Again, the distance is not that long, so even though it might be more challenging, but we're able, generally speaking, to reach this area using a duodenoscope or a gastroscope. The more complicated anatomies are the Roux-en-Y, hepaticojejunostomy, and Roux-en-Y gastric bypass. So Roux-en-Y hepaticojejunostomy, for example, if a patient who underwent liver transplant or had a biliary injury in the past, these patients, regular ERCP is not possible. So using a regular duodenoscope will not be possible. And these patients, however, the distance is not that long. So sometimes we're lucky we can use a colonoscope. and we're able to reach. So we go down to the jejunojejunostomy and then up, and we can reach the hepaticojejunostomy. But occasionally we may need to use deep enteroscopy, which is the double balloon enteroscopy. The most challenging situation is the Roux-en-Y gastric bypass. So as you can imagine, these patients will have very long distance to reach the ampulla. So we have to go from the gastric pouch down the roux limb, all the way down to the jejunojejunostomy, and then all the way up through the biliary pancreatic limb to reach the ampulla. And this is quite a bit of distance, and therefore it's impossible to perform ERCP using a regular duodenoscope or even a colonoscope. But there are several options in these patients. Most commonly used is the lab-assisted ERCP. So this entails the insertion of a port laparoscopically into the excluded stomach, and then we just use the regular duodenoscope and we just perform ERCP in a regular manner. This has very high technical success rate, maybe more adverse events related mostly to these surgery, but again, it remains very safe, and probably it's the preferred approach, especially if the patient needs to undergo cholecystectomy at the same session. The other option is the enteroscopy assisted ERCP using double balloon. I can tell you this is very difficult to perform, has low success rate because maybe 60 to 70% of the time, if we're lucky, we'll reach the ampulla. But even if we reach the ampulla, because the enteroscope has a forward viewing scope, so it will be very difficult to perform ERCP. So it's becoming, it's not used that commonly. The EDGE procedure is a combined EUS ERCP procedure. It's a newer procedure. Entails the insertion of a metal stent from the gastric pouch to the excluded stomach, and then essentially forming a gastrofistula and then going through the stent to perform ERCP. So it's a newer procedure. There are some promising data, but it's only done in certain expert centers. Now, one of the important questions is the role of prophylactic sphincterotomy in patients who are unfit for cholecystectomy. And I have to tell you, this is a very controversial area based mostly on very old data from the 80s and the 90s. And the idea is you have patients who have multiple gallbladder stones and they're not fit to go for surgery. And if you have these stones falling down into the bile duct, causing transient obstruction, causing pancreatitis, for example, causing obstructive jaundice or cholangitis, if you cut the sphincterotomy muscle, sometimes you can prevent the complications. The data so far suggests that this actually is true if you're trying to prevent pancreatitis, which again makes sense because we mentioned what pancreatitis is usually caused by these small stones, which cause transient obstruction at the level of the ampulla, usually leave spontaneously. If you cut the muscle, you kind of prevent this from happening. You just allow the stone to go out before causing any problems. But it has no effect on biliary pain, cholecystitis, and cholangitis. Makes sense because you have cholecystitis really related to stones up here in the cystic duct. So cutting the muscle down here wouldn't do anything. And the other important point to keep in mind that many of the data come from the era of the open cholecystectomy and when there's limited experience with laparoscopic surgery. So just to keep this in mind, and in fact, the most recent Cochrane review published in 2007, which looked at patients who already underwent sphincterotomy and either underwent cholecystectomy or were in the wait and see approach. So this Cochrane review confirmed that if you perform sphincterotomy, removal of the gallbladder will not be necessary if you're trying to prevent pancreatitis. But if you sphincterotomy alone will not prevent cholecystitis, will not prevent recurrent jaundice or cholangitis, and in fact, many of the patients will undergo cholecystectomy. So the current recommendation is patient, if they have biliary complications, should undergo cholecystectomy after endoscopic sphincterotomy, unless really there's a major contraindication for cholecystectomy. And really you should be, if you're still thinking maybe we should just do prophylactic sphincterotomy, it only works if you're trying to prevent pancreatitis, but it will not work if you're trying to prevent cholangitis, obstructive jaundice, or cholecystitis. Quickly about ERCP in pregnancy. The bottom line, it is safe if needed, and the perceived risk of radiation is much greater than the actual risk. Yet, if we have a patient who is pregnant, needs ERCP, it's preferred to be done by an experienced endoscopist and limit the fluoroscopy time to limit the potential risk to the fetus. The indications for ERCP is the same for the general population, and we try to do the ERCP in the second trimester if possible. And it's very important to keep in mind that pregnancy by its own is a risk factor for post-ERCP pancreatitis. Again, emphasizing that we should be limiting ERCP in pregnant patients. Finally, just talk about ERCP complications. I'll try to be quick at the end here. So ERCP is associated with a number of very important complications. The overall complications is about 5 to 10%. Most commonly, it's pancreatitis, but also include cholangitis, bleeding, and perforation, as well as cardiopulmonary complications. However, mortality is very uncommon after ERCP, and it's going to happen usually due to cardiopulmonary complications. Post-ERCP pancreatitis is the most common complication. And it's very important to properly define post-ERCP pancreatitis because sometimes it's used loosely for any high amylase or lipase post-ERCP. By definition, post-ERCP pancreatitis is defined as new or worsened abdominal pain, which occurs after ERCP, and it is associated with 3 times the upper limit normal or elevation of amylase and lipase at 24 hours post-ERCP, and it results in the admission or prolongation of admission. So this is very important definition. Not all patients with high amylase and lipase are considered to have post-ERCP pancreatitis. It's quite common. Up to 10% of the average risk patient will develop pancreatitis, but it can be as high as 25% in high-risk populations, such as young females. Luckily, the majority are mild, but occasionally can be quite severe. Patient may develop necrosis, and some patient will die from post-ERCP pancreatitis. There are some established risk factors for post-ERCP pancreatitis, including previous history post-ERCP pancreatitis. But in general, younger patient, female patient will have higher risk of developing post-ERCP pancreatitis. And there are certain procedure-related factors which increase the risk. As I mentioned, any pancreatic manipulation will increase the risk, including pancreatic sphincterotomy or injecting contrast in the pancreatic duct. So these are some of the important risk factors for post-ERCP pancreatitis. And can we predict post-ERCP pancreatitis? So as I mentioned, hyperamylasemia is very common post-ERCP. About 1/3 of patients will develop high amylase post-ERCP, and it's not the same as post-ERCP pancreatitis. Obtaining, I know we do it quite routinely here, which is obtaining amylase and lipase post-procedure. It's not necessary, but it can help you to predict whether the patient will have post-ERCP pancreatitis or not. Because if the patient has normal or very slight elevation in amylase or lipase post-ERCP, 4 hours post-ERCP, they're very unlikely to develop post-ERCP pancreatitis. Whereas if they have 3 to 5 times elevation of the amylase or lipase post-ERCP, they may develop post-ERCP pancreatitis. So if you do it, it's useful just to kind of know whether the patient is unlikely to have pancreatitis or not. It's very useful if you have patients who have severe pain after the ERCP and they have normal amylase or lipase, you should be thinking of another complication. So how can we prevent it? The most important is patient selection. So again, avoid any unnecessary diagnostic ERCP, use other modalities such as US or MRCP. If you have a patient who you think is high risk, so young female, for example, patient who had previous post-ERCP pancreatitis, probably should be done by an experienced endoscopist, trying to avoid contrast injection to the pancreatic duct. Will also reduce the risk. And as I mentioned, there are certain techniques we can do, such as the insertion of pancreatic stent, IV hydration, and rectal NSAID, which have been shown to reduce the risk of post-ERCP pancreatitis. The most well-established therapeutic intervention is rectal NSAID, which has been shown in multiple studies to reduce the risk of post-ERCP pancreatitis. And typically, rectal administration of indomethacin and diclofenac have been used in the studies. The most recent meta-analysis have shown that this approach will reduce the risk of the incidence of post-ERCP pancreatitis as well as the severity of post-ERCP pancreatitis. And interestingly, for some reason, it only works if you give it rectally. It doesn't work if you give it IV or orally. And it only works with indomethacin or diclofenac. And here in Kuwait, we have diclofenac, which is Voltaren, and it's recommended that we give it to all patients undergoing ERCP before ERCP. So this is a standard practice we do here, there are very few contraindications to this approach. As I mentioned, the second intervention we can do is the insertion of pancreatic stent, which is a very small plastic tube, which is inserted into the side of the bile duct, the pancreatic duct. And the reason why it works is because it preserves the pancreatic secretions, so it reduces the pressure within the pancreatic duct and reduces the risk of post-ERCP pancreatitis. It is recommended to insert a pancreatic stent in patients who are considered high risk, as well as if we enter the bile ducts or the pancreatic ducts. As I mentioned, using the double guide wire technique is a risk factor for post-ERCP pancreatitis, and that's why whenever we enter the pancreatic duct, we always insert a stent. This stent will usually spontaneously fall out and come out in the stool. The patient will not even notice it within a couple of weeks, but we always recommend doing an abdominal x-ray 2 weeks after the ERCP if we do insert a pancreatic stent to make sure that it has migrated out, and you can typically see it clearly on abdominal x-ray. If it doesn't fall out spontaneously after 2 weeks, these patients should be referred for endoscopy, not ERCP, but rather just endoscopy, regular upper endoscopy to remove the stent. Literally take 1 minute to remove it. So it's very simple. The bottom line from this meta-analysis, pancreatic stents work really well for both mild and severe pancreatitis, and it's very safe. So I highly recommend, you see me using this pancreatic stent quite a bit because it works really well and it's very safe. The last intervention is ringers lactate. The reason why we think ringers lactate works for patients with post-ERCP to prevent post-ERCP pancreatitis because lactate is metabolized to bicarbonate, which generates higher pH, and it also prevents the formation of a number of pro-inflammatory mediators. If you look at the studies which use ringers lactate to prevent post-ERCP pancreatitis, they use quite a bit of fluid. So they recommend giving 3 ml per kg per hour during the ERCP. And as soon as we're done from the ERCP, we give a bolus of 20 ml per kg. And then they need to remain on ringers lactate for 8 hours after the procedure. So this is something you can consider. It's very simple. If you want to use an IV fluid after ERCP, I would recommend using ringers lactate because it can reduce the risk of post-ERCP pancreatitis, as can be shown in this meta-analysis. So again, this is another very simple yet very effective intervention that you can do to reduce the risk of post-ERCP pancreatitis. The other important complication is bleeding post-ERCP, which is usually related to sphincterotomy. So again, when we perform sphincterotomy, sometimes it can happen during the procedure. So you can see gush of blood during the sphincterotomy. This is usually self-limited. We can manage it during the procedure, but at times it may develop, patient may develop delayed post-sphincterotomy bleeding, as you can see here. So it can develop hours to days, up to 2 weeks after the procedure, and it usually can be quite severe. The patient may be go into shock, require resuscitation. But again, most of the time we can manage it endoscopically. I'll just skip this part here, but this is how we classify the bleeding in terms of severity. There are certain risk factors for bleeding, most commonly coagulopathy and the use of anticoagulants, and that's why it's very important to manage these appropriately before ERCP, especially if we're planning on sphincterotomy. But even patients with cholangitis will have higher risk of developing bleeding. And also inexperienced endoscopists have higher risk of causing bleeding. But it's also very important to keep in mind that the use of aspirin is not associated with higher risk of bleeding, and the length of sphincterotomy is not a risk factor. So sometimes people tell us just do a small sphincterotomy, we don't cause bleeding. This actually is not a risk factor. So the length of the sphincterotomy is not a risk factor for bleeding. How do we manage? So you're the expert in managing patients with bleeding. It's essentially the same. We just give them fluid or resuscitate them, correct any coagulopathy, transfuse if necessary, and then some patients will require endoscopic therapy. I can tell you most patients with post-sphincterotomy bleeding will stop spontaneously, and we don't even need to do endoscopy, but sometimes they have severe bleeding. We may need to do it to stop the bleeding. And then we have several options, including injection of epinephrine, thermal therapy, clips, and even fully covered metal stents. So this is an example of a patient with severe delayed bleeding post-sphincterotomy. So this is an example where we're just injecting epinephrine. So we're using a needle that injects usually the bleeding at the apex of the side of sphincterotomy. So at the apex here, we just inject diluted epinephrine to stop the bleeding. Sometimes we can use contact thermal coagulation to stop the bleeding, as can be seen here. But at times we might have very severe bleeding. So in this example here, it can be quite severe. We're not able to stop it using the usual technique. And very effective method and safe is the placement of a fully covered metal stent. It works almost all the time. So these patients almost never require surgery or IR embolization. So this is just to keep this in mind as a valid and yet very effective method. Cholangitis can happen post-ERCP, and as I mentioned, usually this happens if you have incomplete drainage or if you have a stent which is occluded. Usually happens with plastic stents. It can be quite severe. Patient can go into septic shock, go into the ICU, but it can be easily managed with repeat ERCP. Very few risk factors, usually older people at higher risk of developing cholangitis, but the most important is procedure-related factors, as I mentioned, incomplete biliary drainage, especially hilar obstruction, and patient with cholangioscopy, after cholangioscopy, and that's why we give them prophylactic antibiotics. The last complication I want to discuss is perforation, since it's uncommon, yet it's the most serious complication. Perforation after ERCP comes in two forms. It can be from the scope itself, which usually causes free perforation like this, or it can be accessory induced, usually from the sphincterotomy, which usually leads to retroperitoneal perforation. The way we classify post-ERCP perforations using the safer classification, which classify them into 4 types. Type 1 is the most serious, where we have lateral duodenal wall damage due to the scope, as in this example here. Type 2 is related to periampullary perforation, usually due to the sphincterotomy. Type 3, where we injure the bile duct, causing retroperitoneal perforation, usually from the wire or the basket once it's introduced in the bile duct. Type 4 is technically it is a perforation, but it's an incidental finding. Usually you find a little bit of air in the retroperitoneum if you do imaging for a different reason. Really, it's not serious at all. Most common is type 2 perforation, which happens after sphincterotomy. So there are certain risk factors for perforation, but again, usually older people, female, and more importantly, altered anatomy are risk factors for perforation. If we perform Precut sphincterotomy, also is a risk factor. And as I mentioned, endoscopists who are inexperienced will have higher risk of perforation. Perforation, as I mentioned, can occur. If it occurs away from the ampulla, usually perforate into the peritoneum, so you'll see air under the diaphragm, present with peritonitis, abdominal pain. But if it's in the ampulla or the periampullar region, will cause retroperitoneal perforation, which is more subtle and more difficult to be detected and present with very subtle symptoms. CT scan is usually the first line imaging modality, or the best imaging modality to confirm whether this is a intraperitoneal perforation or retroperitoneal perforation. And it will also assess whether endoscopic therapy is feasible, whether the patient needs percutaneous drainage, or they should go for surgery. Most important management step in patient with perforation is early recognition, because if you detect it early, you will prevent adverse events such as infections, ICU admissions. So again, you're the expert in managing perforations. You just resuscitate the patient. Most important is to establish diagnosis, hopefully early on. And then number 3 is very important. Not all patients with perforation will require surgery. There are a lot of patients who can be managed conservatively. Many patients we can treat endoscopically, and this is very, very important to keep in mind. So this is just the general approach to managing patients with perforation. But what are the indications? So as I mentioned, the majority of ERCP-related perforation can be managed non-surgically. There are certain indications for surgery, usually if you have a major contrast leak on CT scan, especially if we cannot fix it endoscopically, if the patient is severely septic, despite our conservative therapy or non-surgical management. Obviously, if they have severe peritonitis or large fluid collection that cannot be managed, probably these patients are best managed surgically. But 90% of the time, if not even more, we can manage these perforations endoscopically. This is especially true for type 2 and type 3 perforations. So remember, these are the retroperitoneal perforations. These can be easily managed by the placement of a fully covered metal stent, which not only covers the, so here you can see the site of the perforation, so it not only covers the site of the defect, but diverts bile away from this area. We usually leave this stent for a couple of months and then remove it, and usually the site of the perforation will heal. I will skip this one just for the sake of time, but this is how we manage patients with type 2 and type 3 perforation. The bottom line is most of the time try conservative therapy. If it doesn't work, the patient's sick, you go for surgery. Type 1 perforation, on the other hand, is, again, remember, this is the perforation to the peritoneum. These patients, most of them will require surgery. Most important thing is to recognize them early on, because if you recognize it early, they go for surgery, you can fix the site of the perforation and they do quite well. If you don't recognize it early, they will develop peritonitis and infection, they go septic. However, even though it's not yet the standard of care, there are certain endoscopic therapy we can do for type 1 perforation. There are special clips called the over-the-scope clips or ovesco clips. These are bigger clips that can close perforations up to 2 centimeters, can be used in certain patients with duodenal perforation. Also, we have the suturing device or the Apollo overstitch. Again, this can close larger defect. Unfortunately, it's not available commonly, but this is an option. But the ovesco clips, we do have them commonly, so this is something we can consider. So now I'll just move on to the last part, which is just few questions for you. So we can open up the poll here. So the first question I have for you is, which of the following patients require ERCP? Is it a 55-year-old male who's jaundiced with a bilirubin of 120 and has a new diagnosis of potentially resectable pancreatic cancer? Or is it a 43-year-old female who comes in with severe biliary pancreatitis? Or is it a 40-year-old male with an incidental finding of a 6mm CBD stone on imaging? Or is it D, a 23-year-old male with ulcerative colitis and high alkaline phosphatase who was found to have biliary dilatation on ultrasound? So which of these following patients do you think warrant an ERCP?
So we'll give them a few moments to answer the question. So last few seconds, put your answers in. Ending the poll now. So we have the results on the screen.
So the majority chose C, which is incidental finding of CBD stone. And this is the correct answer. So I'm just going to close. Can you close the, yeah, thanks. So this is the correct answer. The reason for this, as we mentioned, for A, the indication for biliary drainage and malignant obstruction is patient who have cholangitis, severe pruritus, or before neoadjuvant chemotherapy, and possibly very high bilirubin. So this patient has bilirubin 120, otherwise asymptomatic pancreatic cancer, do not warrant routine pre-op drainage. We said for B, there is no benefit for ERCP in acute severe pancreatitis unless the patient has cholangitis, CBD stone on imaging, or they have obstructive jaundice, so bilirubin more than 68 with biliary dilatation on imaging. C is the correct answer because, as we mentioned, all patients with CBD stones, regardless whether they have symptoms, regardless whether the size of the stone, they should undergo ERCP to reduce the risk of future complications. The last patient, just an example of a patient with ulcerative colitis, high alkaline phosphatase, likely has PSC. And as I mentioned, ERCP should not be a diagnostic test. That this patient should undergo MRCP first to confirm whether they have biliary or biliary changes consistent with PSC, and then decide whether they need ERCP. The second question I have for you is a scenario. So we have a 53-year-old female who comes into the hospital with abdominal pain and jaundice, and ultrasound showed biliary dilatation as well as CBD stone, and therefore she undergoes ERCP sphincterotomy, and the stone was extracted successfully. However, in the recovery, she was complaining of abdominal pain. She was a little bit tachycardic at 120. No great fever at 38, but hemodynamically stable. So you reassure the patient probably this is just post-ERCP pain. You give a little bit of analgesia and IV fluid. She's sent to the floor. But the next day, she's still complaining of abdominal pain. She's still having fever. And now she's having leukocytosis. And therefore, you order a CT scan. So I just want to go, CT scan. So this is her CT scan, which is done. So what is the next step in this patient? Would you send her for, would you perform laparotomy? Would you just observe the patient and treat her supportively? Or would you insert an NG or NJ tube, start enteral feeding? Or would you contact interventional radiology for retroperitoneal drain? So what do you think is the best answer in this patient?
Few more seconds. Put your answers in. And the results are on the screen.
Okay, so I guess there's different answers. C was the most popular answer, was 33%. Some people prefer to take it to a laparotomy. And actually, let's see if we can close this. Yeah. So the correct answer is actually observation. And this is a very important message I want to deliver. So this patient has retroperitoneal error, as you can see here. So it has a retroperitoneal perforation. So probably type 2, maybe type 3 perforation post-sphincterotomy. And one of the important messages I want to deliver, these patients are not required to go to surgery. These patients can be managed conservatively. So as I mentioned, for a patient with retroperitoneal perforation, really the indication for surgery is uncontrolled sepsis. So they're quite sick despite your conservative therapy. If they have a large infected fluid collection or large leak that cannot be controlled endoscopically. So this patient has some air in the retroperitoneum, but she's quite stable otherwise. She has some leukocytosis. The best approach, at least initially, is just to treat it conservatively. Since there's no fluid collection, there's nothing in the retroperitoneum except a little bit of air. You can treat it conservatively. Sometimes we can even go in with ERCP and place a fully covered metal stent if we're worried that maybe the patient have some leakage into the retroperitoneum. But the bottom line, you don't need to take them straight to surgery if they're stable, since there are a lot of things we can do conservatively. The numbers or C, insertion of NJ tube, is not probably required because most of patients who have small, so remember this patient had CT scan with oral did not show any leakage. So probably she had a small perforation. Most of the time, these perforations close within a day or two. So probably if you wait a couple of days, she can resume oral feed. So it's not necessary to insert an NJ feed immediately to start feeding. And again, the only requirement for drainage by interventional radiology if there's a collection, and this patient did not have any collection, just a little bit of air. So this is very important. Many of the retroperitoneal perforations, type 2, type 3, can be managed endoscopically or with conservative therapy. The last question I have for you is, which of the following patient required prophylactic antibiotics before ERCP? So is it a 60-year-old male who has metastatic pancreatic cancer and obstructive jaundice secondary to distal CBD stricture? Is it a 23-year-old female with obstructive jaundice secondary to CBD stone? Is it a 55-year-old male with symptomatic pancreatic duct stone? Or is it a 55-year-old female post-duct-to-duct liver transplant who's suspected to have anastomotic stricture and planning on doing ERCP? So what do you think is the correct answer here?
Few more seconds. Put your answers in. And we're ending the poll now.
Okay, excellent. So the majority chose D, which is the liver transplantation, which is the correct answer. So I'll just close this, yeah. So this is the correct answer. So again, we talked about the indications for prophylactic antibiotics before ERCP. As I mentioned, the most important indication is if you don't think we can achieve complete biliary drainage, as in the case of PSC, patient with PSC or patient with Hilar cholangiocarcinoma. These are important indications to give antibiotics before the ERCP. If we're performing cholangioscopy, spineless cholangioscopy, and a patient with liver transplant. So again, they're immunocompromised. So most of these patients, or if not all of these patients, we do give them prophylactic antibiotic before ERCP, whether it's for stricture or for a leak. So just to conclude, ERCP, and this is honestly my most important message from today, ERCP should not be used as a diagnostic modality. It should not be used lightly. It should only be done therapeutically once we confirm a pathology by different imaging. And this is really to prevent the complications post-ERCP, which are quite common and can be quite serious. ERCP is the first-line modality for the management of most biliary pathologies, including CBD stones, obstruction, whether it's benign or malignant, and leaks. And most ERCP-related complications can be avoided. Again, can be avoided by avoiding unnecessary ERCPs. And that's why if you deal with me, you see I rely more on EUS to avoid doing unnecessary ERCPs. But even when complications happen, most of them can be managed conservatively or endoscopically, and most of them luckily quite mild. Post-ERCP is the most, pancreatitis is the most common complication, but now there are certain things we can do to reduce the risk, including rectal NSAID, which is a practice we do it routinely now. Every patient before ERCP get rectal indomethacin or diclofenac, pancreatic duct stent insertion, and ringer's lactate. And finally, perforation is the most serious complication post-ERCP, and type 1 perforation, again, the pre-perforation to the peritoneum, probably at best managed surgically. But there are some promising endoscopic interventions we can perform, and usually can be performed by expert endoscopists, but usually retroperitoneal perforation site type 2 and type 3, most of the time you can manage them endoscopically by the placement of stent and with just conservative therapy with IV fluid. And surgery is rarely required. It still is required, but there are there are certain indications for surgery in these patients. So I would like to thank you very much for your attention. I'll be happy to take any answers.
Thank you, Dr. Ali, for the wonderful lecture. I think we have couple of questions in the Q&A. We have if you can see the Q&A, we have the first question. Would you use a stent with lithotripsy?
So again, lithotripsy, we commonly use it to break larger stones. So lithotripsy, as I mentioned, can be mechanical lithotripsy, can be spyglass with laser or EHL lithotripsy. So to answer your question, would I use a stent? It depends. If we're able to achieve complete biliary clearance, so we're able to remove all the stone as fragments, and we're happy that the patient has good biliary drainage post-lithotripsy, is not a must. But I have to tell you, many of these patients, since we spend a lot of time trying to break the stone, we may not be able to remove all the stones the first time. And even if we're able to remove it, there might be a lot of edema in the area, in the ampulla, for example. They may not have a proper biliary drainage. So we have a lower threshold to insert a stent post-lithotripsy just to ensure that the patient doesn't develop cholangitis, to allow the edema to settle down, and if there are any small fragments that don't cause any obstructions until we come back. So it's not a must, but many of the times, yes, we will do it.
Our second question is more broad, actually, but what is the management of biliary pancreatitis?
So as I mentioned, most of the time for biliary pancreatitis, again, it's just the usual supportive care. IV fluid is the most important thing for the management of biliary pancreatitis, as you're all aware. Nutrition, early nutrition, antibiotic when it's needed. If they have infection or something, you give them antibiotics. So this is kind of the general approach. This is similar to any other pancreatitis, but specifically, as I mentioned, I'm trying to show you the algorithm for the role of ERCP in patients with biliary pancreatitis. As I mentioned, patients with severe or predicted severe pancreatitis alone do not benefit from ERCP and sphincterotomy. However, if they have a CBD stone documented on imaging, if they have cholangitis clinically, or they have very high bilirubin, so the cutoff used by the guidelines is more than 68, combined with dilated biliary tree on imaging, these patients do require ERCP. The other patients who have maybe mild elevation of the biliary tree, a little bit of dilatation, should not go under ERCP as the first line, but rather should go less invasive testing such as EUS or MRCP first. So this is kind of, broadly speaking, the management, similar to any other cause of pancreatitis, but there's a specific role for ERCP. And obviously, as a surgeon, you're the expert of, when you should do cholecystectomy, whether it's the same admission, for necrotizing pancreatitis. There are certain things we can do as well, but that's kind of different topic because there are certain patients who have pseudocysts and walled-off necrosis may require endoscopic drainage, but that's kind of different topic.
Perfect. I think we have another one, endoscopic management for type 3 in cholecystectomy procedure, and number value 3 to 328, how to come, and mortality rate, how to come to 7.9%. Show me the calculation, please.
Type 3, management of type 3, cholecystectomy procedure, endoscopic management type 3, cholecystectomy procedure. I'm not sure if I get this question right, honestly, and type 3,
I think you might be referring to a slide earlier where you had a study.
Let's see which one you mean.
If you mean something else, you can put the question again, and we'll try to answer that question.
Endoscopic management in type 3. I guess type 3. Procedure value 3 and 28. Let's see what they mean. The table. Um, 7.9%. Let me see. Okay, I'll go back to the slide and maybe I'll see if there's numbers here. Yeah, that's the 7.9%. Maybe that's what you mean, because that's the 7.9% mortality. I'm not sure there's type 3. Where's the type 3 cholecystectomy came from, honestly. Yeah, I'm not sure, honestly, what that means. But if that's the mortality we're talking about, this is just, I'm taking it straight from this Cochrane review, so I didn't do any calculations or anything. It's just straight from this Cochrane review. And this is a reference if you'd like to see it. It's by Matt Gallister and Cochrane review, published in 2007. I'm not sure if I answered your question because that's the only thing I can see which has a mortality of 7.9%. It's not related to any type 3 cholecystectomy. Just so this slide just talks about patients who have biliary type of complication, whether it's pancreatitis, cholecystitis, cholangitis, who required endoscopic sphincterotomy, and then these patients were considered either too high risk to undergo cholecystectomy, but some of them did go or I shouldn't say too high risk, but some of them did go cholecystectomy, and others, the surgeons preferred to wait and see approach. And these studies, so this is based all on RCTs actually, so it's not observational studies. And this systematic review found the patient who were in the wait and see approach that they did not go cholecystectomy had a mortality of 14%. Why the patient underwent cholecystectomy had a mortality of 7.9%? I don't know, honestly. Maybe they're just a bit older, and during follow-up, some of them died. It's not necessarily related to their cholecystectomy. It's not really necessarily related to their biliary complication. It's just during the follow-up. But again, this is all based on randomized control studies. And if you want more details, you can go back to this Cochrane review from 2007.
I hope that answers your question. And I think this is the last question we had. I think you've been very thorough throughout the lecture. Thanks, it's been amazing. And for an ERCP, it's one of the cornerstones of our tools in the surgical world. So it's very important for us to hear from your experience. Thank you so much for giving us your time. It's been a pleasure to have you with us, Dr. Ali.
Thank you very much for this kind invitation. Again, it's been a pleasure, and hopefully you learned something from today.
I'm sure everybody learned as much as I am. It's been a great having you with us. And once again, as usual, towards the end of the lecture, I'd like to remind you to register for our next session of Surgical Fix this Friday by Dr. Noreen El-Bloushi, hepatobiliary surgeon from Oman. And on Saturday, we'll be resuming our plastic surgery foundation course. So you can register using the QR codes or the links in the chat, and we'll be sending out the certificates by email. So stay tuned and check your email. Once again, thank you, Dr. Ali, and thank you everyone for attending today.
Thanks, and good night.
Good night.